Welcome to Physiological Interpretation of CTG, Cardiotocograph, asking the question, why today is the right day for an urgent paradigm shift. In the part one of this series, we are going to look at the concepts of physiological interpretation of CTGs. I would like all of us to go back and imagine that we are a fetus, in other words, to our fetal life, and then experience the challenges that we all faced as human fetuses. The first challenge we faced was, unlike toddlers, children, and adults, who are lucky to have 20% atmospheric oxygen so that they can take in oxygen whenever they need it, we were immersed in a pool of amniotic fluid. Water. Not for 9 hours, not for 9 minutes, but for 9 months, which meant that we needed to have effective adaptation and mechanisms to deal with this hypoxic environment for 9 months. Imagine being a scuba diver for 9 months. The second challenge we faced was that at one point in a time, our moms would say, it's time to go out. And the human labor has been described as one of the most dangerous journey that we would ever undertake in our life, if you look at from the kilometer distance covered. We had to go through the bony and soft tissue passage of our moms, during which our head is going to get squeezed, our quad is going to get squeezed. And our moms had to contract about 3 to 4 times in 10 minutes, lasting for a minute each. And that meant that our umbilical cord that supplied oxygen from the placenta got squeezed 3 to 4 times in 10 minutes. And we know that the uterine arteries, they come from lateral to medial side. And the branches of the uterine arteries, they had to traverse through the myometrium to supply the placental bed. So you can imagine, when my mom contracted the myometrium, all these tubes that were going to supply my placental bed to give me good oxygen, they were all squeezed. And my mom did this for 8 to 10 hours. And imagine that's your mom, and you are a child learning to do scuba diving, and she jumps in and squeezes the tube that connects your oxygen cylinder or tank to your nose. So you can imagine, as human fetuses, 3 to 4 times in 10 minutes for 10 hours, we had threats of reduced oxygenation to our central organs. So which meant that we had to develop intelligent mechanisms to deal with that intermittent hypoxic stress that happens in labor. We had the third problem, and that is, if you look at the skin, if you take a swab from any part of the skin in your body, it will have lots of bacteria. And my mom's lining of the vagina is nothing but the continuation of the skin of her upper thigh. And therefore, the upper part of the vagina contains lots of organisms which are normal commensals. It is okay for her, but not for me, because I don't have any acquired immunity yet. And any time these organisms can enter my amniotic cavity, and because I do fetal breathing movements, these organisms can enter my lungs quite easily and cause congenital pneumonia and fetal inflammatory response syndrome, leading to fetal sepsis. And by any reason, I poo inside, I pass meconium, either due to physiological maturation of the gut or due to some kind of inflammatory or hypoxic stress, I'm going to be covered with meconium and its toxic contents, and can increase the risk of meconium aspiration syndrome if hypoxic stress is combined with the presence of meconium. Then I need to deal with the maternal environment. My mother's blood pressure can fall in labor, especially if an anesthetist gives an epidural. My mother may not give enough oxygen because she has got problems in the respiratory tract like COVID-19. Her temperature might increase, which means that her metabolic requirement increases, her oxygen consumption increases, and transfer of oxygen across the placenta is not good, not so good. More importantly, when her temperature goes up, the temperature gradient gets affected, and I can't dissipate the heat of my metabolic rate effectively to the mother. That increases my core body temperature, increasing my risks of injury to my neurons. Then, of course, we have my species, Edwin the obstetrician. Sometimes we know that a muscle has 4 properties: frequency, duration, strength, and the basal tone, any muscle in the body. But some obstetricians like me, we lose what we learned in medical school, and we define uterine hyperstimulation based only on frequency. And we miss ongoing hyperstimulation due to tone, increased basal tone, or duration of contractions. And you can imagine if the contractions are messed up in any way, that's going to significantly increase the risk of hypoxic injury. Sometimes Edwin Chandraharan tries to deliver the fetus by vacuum or forceps because he doesn't understand fetal physiology. He panics about CTG. That causes trauma. That causes increased intracranial pressure on the fetus. Just imagine someone, you're just waiting here without any knowledge that someone is going to apply 2 big spoons on either side of of your head and lock it and then pull you out. That's what babies face. If we need to really do it, it's okay, but not because of CTG misinterpretation. And sometimes in late first stage or second stage of labor, when my head is really stuck and I'm going to try to come out, Edwin Chandraharan looks at the CTG, he doesn't understand it, he panics, he takes me through an emergency cesarean section, drags me out. Just imagine the force he uses to disimpact my head and pulls me out, obviously causing angular tears to my mom, which means she's bleeding, she's getting hypotension, and I'm not getting enough placental blood flow. And sometimes, when his skills are not good, he does both. He tries a vacuum, he tries a forceps, pulls me down, fails, and then does a cesarean section, pushes his hand inside, asks a poor midwife to push me from down, and then takes me out. And sometimes he also gives a bonus cut to the mom as well. So there's an episiotomy, there is vacuum, failed, forceps, failed, and an emergency cesarean section. So as a human fetus, these are the challenges that we face. But we are a very, very clever fetuses. But Edwin, who is managing us, is not so clever. You know why? When he doesn't understand fetal physiology, he goes this way, finds any piece of my skin, cuts it, and he thinks he's checking the oxygenation of the brain. And I'm telling him, no, Edwin, this is my skin. It is my peripheral non-essential tissue. Please don't take a sample from there. Please ask your friends who were in medical school with you, who are now cardiologists or neurosurgeons or doing general surgery. They will tell you that you only take sample from an artery. That's what reflects the brain, the central organs. They will also tell you that when you are stressed, your skin undergoes peripheral vasoconstriction, and therefore you are likely to have acidosis. But guess what? Every other surgeon who cuts their patients, they have the decency to suture the wound. That's what every doctor does. But Edwin Chandraharan hasn't developed technical skills to suture the wound that he is cutting. So he leaves it open for all these bacteria to enter and cause scalp abscess, Cases of meningitis have been described. Cases of CSF leakage has been described. Cases of fetal scalp hemorrhage and hemorrhagic shock has been described due to this quackery practice. But he is still doing that due to CTG misinterpretation. So let's go now and understand the concepts of fetal physiology. So we don't have to do these historical malpractices, and we can understand the challenges of a human fetus and try to help them. Because of the hypoxic environment, fetuses have been doing their homework. If you look at the blood flow to the fetus, oxygen carrying capacity of the fetus, and the affinity to hold on to oxygen at low oxygen tensions, you will find that they have done their homework. Blood flow 300 mL per minute is much higher if you are considering kilogram body weight. Remember, 300 mL per minute is for 4 kilogram baby. Mom has 1000 mL per minute, but she has got 70 kilograms, 40 kilograms, 50 kilograms. We have got fetal hemoglobin, which has high affinity for oxygen. We also, as fetuses, had a higher concentration of hemoglobin, almost doubled it. And our heart rate is almost double that of an adult because the heart rate is about 110 to 160. And whenever we are stressed, we are able to quickly, as fetuses, shut down the periphery, including the skin, muscles, liver, spleen, and then divert the blood to the central organs, brain, heart, and the adrenal glands. And that has enabled us to live in a hypoxic environment. And just have a look at these numbers. If you're a mom, your arterial oxygen saturation is 90%. But if you're a fetus, the umbilical vein that brings good oxygen to you, which is similar to an artery in the adult, is only 70%. You and I cannot live with 70%. We need intubation ventilation. But fetuses can because of all these adaptations they have had. Same thing with your partial pressure. Partial pressure in the artery is 100 millimeters of mercury in the mother. But if you look at the fetus, in the umbilical vein, the partial pressure is only 28 millimeters of mercury. And that's why many of us call this situation Everest in utero. If you go to the top of the Mount Himalayas and then try to live there for 9 months, this is the kind of oxygen saturation you will be exposed to, and you would be asking for help. But these babies, because of these intelligent adaptation, they are able to live without any problem because they have the special hemoglobin. They have more of the hemoglobin and they have a more blood flow. So we can understand why we needed to introduce intrapartum fetal heart rate monitoring, because as they were pushed down, there were intermittent reduction in oxygen coming to us due to contractions, squeezing the placental blood vasculature, the uterine blood vessels that are supplying the placental bed, and also squeezing the umbilical cord. And also, if you squeeze the head in the deep maternal pelvis, you're going to increase the intracranial pressure. That's going to decrease the carotid circulation. So because of this, we were at the risk of hypoxic ischemic encephalopathy and risk of intrapartum related perinatal deaths. So we introduced fetal monitoring. If you are in a low-risk labor, it is either with a PNAD or a modified technology, which is Doppler, which is done every 15 minutes in the first stage of labor or 5 minutes in second stage of labor. If it is considered to be a high-risk situation, then we introduced cardiotocograph. The idea was very simple. You are looking for fetal heart rate changes in response to the stress toco contractions, so that we can timely intervene to avoid hypoxic injuries and perinatal deaths. But we must remember that it is not one against the other. It's not doing cesarean sections and trying to think that we are preventing hypoxic injuries because we don't understand CTGs and increasing the cesarean section, vacuum and forceps and their complications to the mother. No, being a good doctor and a good midwife is all about understanding fetal physiology so that we do the right intervention to the right fetus at the right time. At the same time, we avoid unnecessary interventions and their complications to the mother. And that's why we need to avoid misinterpretation of the CTG. So if you imagine you are a fetus and you are showing a very good heart rate on the cardiotocograph, as you're coming down, your head is going to get squeezed. Your umbilical cord is going to get squeezed because the contractions are now more frequent, more stronger, and you are in a bony pelvis compared to when you are in the abdominal cavity. And which means that you are going to show a stress response. And we need to understand what that stress response is without, which are happening in relation to the contractions, without us panicking about this by calling these decelerations various names and taking a knife, going through the cervix, cutting the skin of the fetus, kidding ourselves that we are checking the central organs. So normal suspicious pathological classification, which is a traditional classification introduced 50 years ago, the main problem is we don't agree with each other and we don't even agree with ourselves. So if you look at studies, and this is only because, not because obstetricians and midwives are bad people. No, we are relatively clever, I think. It's just that we have introduced this technology without any thinking. We didn't do randomized controlled trials that other doctors do, other nurses do. We just introduced the technology without research and then ran around panicking about classifying decelerations as to how they look like. That's what has happened to us, which means that what the professor thinks is not what you think, what the midwife thinks, because we're all different. We can't identify shapes. Can we? All of us are not good at identifying the same shapes. We don't see the same picture when you go to an art gallery because we are all different. And therefore, when you make a guideline or system which is dependent on sole pattern recognition, it is not rocket science to understand that we were going to fail. So not only there's inter-observer variability, there is also intra-observer variability. Not only we are a problem, frontline clinicians, but experts are also having the same problem. You know, these experts, they say they know CTG, and they go to the courts and tell the judges, hey, I know CTG, and Edwin is bad because he got it wrong. Those experts, they also can't get CTG right. Not only there's inter-observer variation, there's intra-observer variation as well, which means Edwin Chandraharan does not agree with Edwin Chandraharan. You give me a CTG today, I say it's normal or suspicious. 2 weeks later, you give me the CTG again, I say it's pathological. But my good friend Diego from Portugal, he did a very good study, published in the PJOG about 11 years ago. What he showed was, when you give a CTG to an expert, those who go to courts as well, and later give them outcome data to say this baby did well, this baby went to the neonatal unit. You know what these experts did? They changed their own classification. So once we know the outcome, we are all becoming wiser and blaming our junior staff and others, not realizing that's only because we know the outcome. When we are sitting across a risk management meeting, we know the outcome. So we become experts. We say, oh, they should have delivered this baby half an hour ago. No. That's only because you know the outcome. And this is the nice guidelines used in the UK. You can see how complicated this is to be used at 2 in the morning. Look at the features, look at the numbers, look at the minutes, look at the percentages, and ask yourself, if you are a newly qualified midwife or doctor, would you want to be put through this system? Don't ask me which version is it, because I lost count of them. You know, those who produce these guidelines, they are getting confused all the time, and they keep revising the guidelines every few years. So I have lost count of which version is it. Similar to the British Parliament with number of prime ministers. If you ask me who is the prime minister now, I have to stop and think, because every few months we are having changes in the prime minister. Similar to, I think they are just copying our CTG guidelines. So if you just take a step back and ask yourself, around the world, you have FIGO guidelines, American ACOG guidelines, you have NICE guidelines, physiological guidelines, Canadian guidelines. You have got guidelines for each society, each country, which are different to each other. I used to be scared when I went to Scandinavia to do CTG master classes, because there, if a woman from Sweden crosses the border and goes to Denmark, that baby will be treated so differently because their guidelines are so different. How can that be? It's a human baby, it's a Scandinavian baby. How can you treat the Scandinavian baby differently? Think of ECG. From the time we became medical students to now, the waveforms are the same. Cardiologists are not running around changing the ECG guidelines because they don't understand the waveforms. They know ST segment changes, they know T wave. It has been the same. If you go around the world, they all look at the ECG the same way. They don't have different guidelines on ECG for each country. But imagine Edwin Chandraharan becomes a cardiologist. He becomes a cardiologist without understanding cardiac physiology. And others don't know about it yet. So he has a guideline and he has a power. He sits in a Royal College and therefore or national body, and therefore he has the power. And therefore he makes a guideline. The guideline is normal ECG, suspicious ECG, pathological ECG. But because he doesn't understand and he calls the ECG suspicious, he knows that he has to do something about it. Otherwise, his young trainees and midwives will be asked, or nurses will be asking him, Edwin, suspicious? What do we do now? So he says, give water to the father of the patient. If we do that in adult medicine, the father of the patient will tell us off. He will tell us, come on, Edwin, this ECG was done on my son, not on me, and are not thirsty. You cannot give water to me thinking that giving water to me to somehow will correct my son's cardiac changes. You need to learn physiology, Edwin. That's what the father would say. Yeah, I say, well, if the ST segment change is going for more than 30 minutes, it's a pathological ECG. And I say, well, if the ECG is pathological, I want to cut the patient's skin of the scalp. You know why? The skin of the scalp is very close to the brain. Have you ever seen a cardiologist cutting the skin of the chest to look at the heart? A renal physician cutting the skin on the loin to look at the kidney? A neurosurgeon cutting the skin of the head to look at the brain? No, obstetrician scan. But I'm a cardiologist. So I'm making this crazy guideline saying that you take a blood sample, and if it is acidotic, you take the father of the patient for laparotomy. You know what the father would say? Edwin, which medical school did you go to? Did you buy your medical school certificate on eBay? Because first of all, you should not be cutting anyone's skin because that's a non-essential tissue. It doesn't reflect blood supply to the brain or the heart. And it is a very, very bad tissue to test. Learn from other doctors, Edwin. Secondly, Edwin, you are testing my son's skin. And based on the result, you are subjecting me to a major operation, laparotomy, that can have bleeding, infection, sepsis, etc. I don't agree with you, Edwin, and I wouldn't do it. Well, you know that we are using CTGs, and we don't understand CTGs, and we are calling the CTGs as normal CTGs, suspicious CTGs, and then we are giving water to the mother, and the poor woman doesn't realize that it is wrong, and therefore she's accepting it so far. Even if she's not thirsty, even in winter, when she's going to the toilet all the time, when she has got 50% expansion of blood volume and 50% increase in the glomerular filtration rate, that if he's making her to go to the toilet all the time, we give her more water to waste it and to trouble her and to cause dilutional hyponatremia and cause electrolyte imbalance in her because we didn't bother to read CTGs based on physiology. But guess what? If these decelerations are going for more than 30 minutes, we classify it as pathological CTG and cut the skin of the fetus, which is squashed in labor with caput and molding, and therefore it's going to be acidotic even when the fetus is fine, and take the poor mother to the operating theater, telling her the lie that the fetus is in trouble because the scalp sample is acidotic. She hasn't realized it yet, but she will one day, that this is what we did to them. And, what saddens me is that now our specialty, if you put midwifery and obstetricians combined, maternity service, 80 to 90% of our workforce is a female workforce. How could we put women in trouble like this? Telling them that the fetal sample of the skin is wrong and therefore your fetus is in trouble, and taking them for major operation so that they can have postpartum hemorrhage and accreta, increta, percreta, uterine rupture next time. And we think that they won't find out. They are going to find out. And that's why we need physiology. And now you can see, this is the each baby counts report. As the name says, we counted each baby who sadly died or had severe brain damage due to an intrapartum related event. You can see 121 babies died in 1 year in the UK. 165 babies had succumbed in the neonatal period, sadly, after hypoxic injuries. And 859 babies did not have mild or moderate brain injury, as the report says severe brain damage, potential to end up on a wheelchair. And 74% of these cases, the report says, a different care would have given rise to a different outcome. It's sad, and 33% of these babies had CTG misinterpretation, according to this report. Now, it is final report, because do you know why? Sadly, we did not listen to Albert Einstein, who said insanity is repeating the same mistakes over and over again, expecting different results. So that when the first report gave the same findings, and the number of babies who died or got damaged was 950, so much less than later on. We increased by about 200 later on. We didn't have the courage, humility, and honesty to say, well, we have a wrong tool. Let's stop counting. Let's change the tool that says normal, suspicious, pathological. No. We counted again and again and again 5 times. That is 5,000 babies. That's what we did. Until now, luckily, we have Miss Donna O'Cunton. She's a very clever midwife. She's going into hospitals to uncover all the scandals, things that we have been covering up. I mean, just imagine if 1,000 babies and 74% different care would have been giving us a different outcome. Don't you think it's simply because evident for those who are counting these babies, there's 700 babies a year. In 5 years, it's going to be 3,500 babies. Wasn't it obvious? If 33% out of 1,000 babies approximately had CTG misinterpretation as the cause for their demise or brain damage, wasn't it evident? If you go to a high school, 33% of 1,000 is 330 babies. Wasn't it evidence that it's going to happen? That in 5 years, if you keep counting, there's going to be 1,500 babies, but we counted. And this is a couple of weeks ago. You can see 1,500 cases in one hospital. And about 70 midwives and doctors are being referred for their GMC, General Medical Council and General Nursing Council, but it is not their fault. They are the innocent victims. The real people who should be accountable is those who produce the tool nationally, knowing that this will cause problems, and those who allow this tool to be used. Those are the ones who should be held accountable, not the frontline midwives or doctors. And women are going to find out, and their families are going to find out, that one day in the UK, we call ourselves Great Britain and world-class maternity service. We use water to treat chronic hypoxia and chorioamnionitis, which have been often classified as suspicious CTGs. Imagine in a medical ward, someone has bronchial asthma, and the doctor or nurse treats bronchial asthma by giving water because they didn't understand what increased respiratory rate meant. But water, not even to the patient, but to the patient's mother. We will be having reports like that in that medical ward too. And we, from the UK, have been teaching developing countries how to look after their women and babies. And those guys and girls, midwives and doctors in those developing countries are going to look at all these reports and say, hey, what is happening in the UK? You're trying to tell us how to improve care. In your country, if you're a Black or an Asian woman, you are likely to die more than twice during pregnancy and childbirth. If you are a baby, you're in a very difficult situation. 20% of your maternity units have been deemed unsafe, and you are trying to come and tell us how to improve care? Why don't you first improve care for your women and babies and families first? And you're giving water as treatment for hypoxia? Why don't you improve your knowledge first before coming and telling us what to do? That's what is going to happen. And in many parts of the world, I grew up in Africa, water is very scarce. Children are walking for miles to get clean water. And here we are, wasting water in our labor wards due to lack of knowledge. We are wasting liters of water for suspicious CTG, and if Ms. Greta Thunberg, who fights for the environment, learns that we are wasting so much of clean water due to lack of knowledge, she will, I'm sure, bring climate change activists camp outside our labor wards until we learn physiology. So you might say, I'm really worried about this CTG. It's true. But when we go back to our medical school or midwifery school knowledge, we know that we are all exposed to hypoxic stress in our daily life. Think of running, jogging, going to the gym. They are all hypoxic stresses. And we compensate for that hypoxic stress. It is only when we go from compensation to decompensation, our metabolism changes from aerobic to anaerobic, and we produce lactate. We become acidotic. It's the acidosis that damages our organs and tissues and makes us drop our blood pressure, and we finally die due to acidosis in the myocardium and cardiac arrest. So instead of saying I'm really worried, the question we should be asking, is this fetus worried? Because we are not there to treat the CTG. We are trying to treat the fetus, to recognize the condition of the fetus. Is this fetus worried due to the intrapartum stress that the fetus is exposed to? Are there reduction in the blood supply to the central organs? Because if you look at guidelines, based on the morphology of the decelerations and the fact that they are repetitive and they have a particular duration of deceleration, depth of the decelerations, you can classify the CTG as suspicious or pathological. But the next question for us clinicians, how reliable is our pattern-based classification in diagnosing ongoing fetal acidosis? Because remember, we are there to detect acidosis. Acidosis is the one that damages or kills, not stress. Going to the gym every day and coming home is not going to kill you unless you become decompensated in the gym and go from aerobic to anaerobic metabolism and produce lactate in your heart or brain. That's what damages or kills you. So let's look at it from a scientific point of view. If you collect 100 of these ugly pathological looking CTGs and ask yourself a question, what is the likelihood of metabolic acidosis? Then let's apply scientific evidence to get that answer, because that is the key question. Yes, CTG is pathological, but if I do a cesarean section or vacuum of forceps in this case, what is the likelihood of the baby becoming acidotic? So that I can give that information honestly to the woman, instead of saying your fetus is in distress, which is an old term. I can give scientific answers so she can weigh up and make an informed decision. So luckily we had Professor Richard Beard. In 1971, he looked at CTGs, about 289, and then he gave us this answer. The only problem of this paper is that, remember, this is 1979, we didn't have any research evidence in intrapartum care, and therefore what did Prof. Richard Beard's generation do? They compared everything to the adult physiology. And then, adult physiology 7.35, 7.45 is the normal pH. So let's cook and put 7.25 as the cutoff for metabolic acidosis for fetus, because you know why? In adult medicine, we get worried when the fetus drops to 7.25. So that was the idea. But drawing the line there, he was able to show that the 60% of these pathological CTGs had normal acid-base balance at birth. In other words, 60 out of 100 cesarean sections they were doing for pathological CTG were potentially avoidable. False positive rate for 60%, and we knew that for a long time, thanks to Prof. Richard Beard. But this is 2022. If you add the current scientific evidence, because now we have data from large population studies. In 2015, I was part of the FIGO consensus guidelines, and we looked at evidence and drew the line not at 7.25 for metabolic acidosis. The definition is 7. And Americans, they are far ahead of the game, and they changed it to 7 much, much earlier. We were a bit slow in Europe to change. So 7. We don't say metabolic acidosis is 7.2y. Umbilical arterial pH of 7, which means if you draw the line at 7, look where we are. More than 90% of these pathological CTGs are normal from acid-base balance point of view. In other words, if you go and do cesarean sections for pathological CTGs, 100 of them, 90 of them are potentially avoidable, and the woman is going to know this one day, that we blindly followed guidelines. Because the vast number of pathological CTGs, as we do today, they are totally unnecessary when they are done for suspected fetal compromise, based on guidelines that say normal, suspicious, pathological. And this is a paper from last year, about a year ago, and you can see when they looked at 30,000 babies and they are trying to look at the correlation. Yes, the vast majority of all the studies are showing, and that's the international consensus in the FIGO guidelines as well, over 99% of pathological CTGs, the cesarean sections and operative interventions performed for pathological CTGs are totally not necessary. So when I come to the labor ward, I see this CTG, and if my professor panics, I must tell him, don't worry, professor. Calm down, dear. Yeah, just calm down. This CTG, though you're panicking, the false positive rate is over 90%. What you panic, but I am not panicking. We have a high inter and intra-observer variation. This CTG professor, does not predict the perinatal outcomes. That is the scientific evidence. And professor, when you do the Cochrane review, you see the latest Cochrane review, it is very clear that CTGs, the way you are using, professor, into normal suspicious pathological, does not improve perinatal outcomes. And that's why, professor, we are going to look at physiology now. So we all want a positive energy in a balance in the myocardium. You remember, heart is a pump. If you give enough energy and maintain it in a positive energy balance, it's going to pump. Well, it's a muscle. And therefore, the cardiac output is going to be good. Rest of the organs are going to be good. So positive energy balance means providing more oxygen than demand all the time to our central organ. And then it leads us to an aerobic metabolism, which is good, that it produces more energy. So you have got good cardiac contractility, good ventricular contraction, good cardiac output, and all the organs are extremely happy. And this is where we want to be. Suppose if our myocardium goes into negative energy balance, which means the amount of oxygen that is delivered to the heart is no longer sufficient to meet the metabolic demands. That's what it means. It can happen either due to reduced supply. For example, if you have a coronary artery disease, if you have got COVID-19, bad pneumonia, bronchial asthma, you're going to have reduced supply to the myocardium. Or it can be due to increased demand, heavy exercise, for example. Or if you have sepsis, when the metabolic demand of the myocardium has increased, then this demand-supply equation is going to get affected. So just imagine if you go into anaerobic metabolism because the amount of oxygen is no longer sufficient to meet your cardiac metabolic demand. In the gym, when we run fast, our calf muscles get into pain, and that's because we are shifting our metabolism from aerobic to anaerobic to produce lactate, and that lactate causes pain in the calf. And what do? We slow down. We stop the exercise. In the same way, when you put lactate in the heart can no longer continue to pump at 150 for a fetus. It drops down to 140, 130, 120, 110, and terminal bradycardia. And that's why this is called a step ladder pattern to death, as if you are going to your death in steps, down, obviously not up, downward steps. So what do we do as human beings to prevent this? When we run, jog, swim, cycle, whatever hypoxic exercises we do, we have increased the workload of the heart, we have increased the demand of the heart. If you increase the demand of the heart, we are going to go into anaerobic metabolism. But automatically, without thinking, we increase the rate and depth of respiration. That's what we do in the gym. When you run and catch a bus, what are you doing? You're trying to protect the myocardium from acidosis. So as adults, we increase the oxygenation rapidly, increase the supply to the myocardium, and avoid anaerobic metabolism to maintain our myocardium continuously in positive energy balance. That's what we do. So if you and I ask a question, how do adults, toddlers, children respond to hypoxic stress when they are running, jogging, etc.? They use tachypnea, increased respiratory rate, and they become tachycardic to pump that oxygenated blood to central organs and to the muscles so they can continue running. And that's our normal physiological exercise. We learned in medical school, first year. Now, at the start, whatever our physiology is not going to be the same after 10 minutes of running, 15 minutes of running, 30 minutes of running. We are going to get worse and worse because we are going to utilize our resources, our buffers. We get more and more tired. And that's life. We all know that. And when we come to a point where we need extra resources to supply the brain and the heart, we release catecholamines, adrenaline, and noradrenaline. They not only increase our heart rate, they also cause peripheral vasoconstriction and divert the blood from the skin to the central organs and the muscles. And we know that. And that's the reason why clever doctors from other specialties, when they are looking at men and women who are stressed, they don't take the blood sample from the skin because they know if you take blood sample from the skin, it is going to be acidotic. And that acidosis is a good acidosis. It's a peripheral tissue acidosis. The peripheral tissues are sacrificing the oxygen to become acidotic so that the central organs are well oxygenated. That is why clever doctors who went to proper medical schools, they take arterial blood gases. They don't run around cutting the skin of the patients to look for acidosis. Skin becomes acidotic as a normal compensation. Now let's look at these individuals who are running, men and women, you can see, and ask yourself a question. Well, what are the chances of these guys and girls completing this marathon successfully? And you would say age, important, pre-existing disorders, if they have pre-existing diabetes, coronary artery disease, or they are coming with viral infection, they are not going to complete. The speed at which they run is very important. Individual reserve. If the environment is too hot, they can cause peripheral vasodilatation, which means you can't constrict and then supply your central organs. You have a heat stroke there. And then duration of running is so important. If you have been practicing to run a marathon in 3 hours per se, and if someone forces you that day to run for 5 hours, 2 hours extra to total 5 hours, you're going to collapse only because you have utilized all your resources. And the ability to centralize is also important. Imagine Edwin Chandraharan, after retirement as an obstetrician, wants to become a physical trainer. So he wants to make guidelines. So he says, well, for marathon runners, all marathon runners, it doesn't matter you're a man or a woman, old or young, all marathon runners, if your heart rate is 60 to 90, you are normal. So guys, you look normal because your heart rate is normal, according to me. If the heart rate is between 90 to 100 and lasts for 15 minutes, you are suspicious. And if the heart rate is 90 to 100 for more than 30 minutes or more than 120 for 10 minutes, you are pathological. That's the guideline I have made. And I'm applying this guideline without any individualization to all the marathon runners who are running the marathon. Some of them have poor reserves. Some of them are not as fit as others, but all have to fulfill my requirements because I'm sitting in a national guideline body and I've suddenly become so important to put my name in that guideline. And therefore, everyone says, oh, look, that is Edwin. He made that, that guideline. He's the one. Then everyone calls me to conferences. Lawyers call me as an expert witness. So I'm very happy, but I made this guideline. I'm telling this guy, well, because of my guideline, you're suspicious. Guess what I'm going to do? I'm going to go home and give water to your mom. And he says, come on, Edwin, come on. Seriously, my mom is not running. You're looking at my parameters. Why should my mom, who is resting at home, actually she has had 1 liter of avocado juice just now. Why do you want to give her more water? She's not thirsty. This guy, I'm saying, hey, look a bit pathological. Compared to these other people who have lots of hair and can't reach the scalp, you seems to be easy to reach, like cervical dilatation 6 centimeters, so easy. It's easy to reach. And therefore, I'm going to cut your scalp. These guys, I can't. I will say, don't know what to do. But you, I can cut your scalp because I think your scalp might tell me something about what the brain is doing because it's very close. But guess what, boss? Based on that result, I'm going to go home, drag your mother in an ambulance, and take her for a laparotomy. Just imagine if I do that. Similarly, if you're asking yourself, what are the determinants of a successful intrapartum journey of a human fetus who is subjected to hypoxic stress just like the marathon runners because the cord is getting squeezed 3 to 4 times in 10 minutes, placental blood supply is getting cut off, and the head compression causes increased intracranial pressure and reduces carotid circulation. So if that is the situation, you are going to, as a human fetus, show a stress response on your physiology. And the chance of successful outcome depends on your age. Are you preterm or post-term or term? Pre-existing disorders. Do you come with chronic hypoxia? Do you come with chorioamnionitis? How fast you're running? Is it spontaneous labor, where the nature gives lots of time between the contraction to oxygenate yourself? Or is it a labor induced by oxytocin? What is your physiological result like? Your immediate environment is the mother. If the mother is hot, maternal pyrexia, your metabolic rate will increase, your oxygen demand will increase, you will go into hypoxia and acidosis much faster. You have been programmed by nature to have certain resources to undertake a normal labor of 8 to 10 hours. But here, Edwin is on the shift. He has given prostaglandins first because that's what his guidelines say. And then he's starting oxytocin when your mom is only 3 centimeters dilated. And he cannot think broadly. So he wants the midwife to maintain 3 to 4 contractions in 10 minutes from 3 centimeters onwards. And you are telling, no, Edwin, nature is not like that. Normally, in latent phase, you only have 1 or 2 contractions. It's only at 8, 9 centimeters, you have stronger contractions for 3 to 4 in 10 minutes. If you start 3 to 4 contractions at 3 centimeters, Edwin, what is going to happen to my mother's uterine muscle? It is a muscle. If you start to make it work for a long time at a higher intensity, it's going to produce myometrial lactic acidosis. It's going to stop working, and you're going to lie to the mama that she's not progressing. Actually, you are the one who caused her not to progress, Edwin, by your quackery practice. And Edwin, if you stress me with 3 to 4 contractions right from 3 centimeters, and I've utilized my buffers, I've utilized all my resources, how do you, Edwin, expect me to withstand second stage of labor? You are the one who caused the problem, Edwin. And especially if I'm already growth restricted or my organs are smaller. So when I'm stressed, I can't really divert the blood from the liver and the kidneys because they have already given up their blood. And that's why they are small. I don't have organs to redistribute. You can't wait for 30 minutes on me. And if you start oxytocin on me, and because you are worried I'm growth restricted, you are inducing me and prolonged oxytocin, are you surprised, Edwin, that I'm getting damaged? And all those reports are coming out one by one. Are you really surprised? So our role is to ensure that we take the baby to the finishing line after considering all these parameters. But imagine then, I just arbitrarily group these features into different boxes. And I produce a national guideline. Very happy. Everyone is calling me to give talks because I produce this national guideline. The lawyers, the defense lawyers are inviting me all the time to give opinion because I have produced this guideline. Due to my lack of understanding, I'm calling some of these features suspicious and I give fluid to the wrong person. And some of these things, features pathological, I'm cutting the wrong tissue to check for acid and performing the wrong operation, which is vacuum forceps or cesarean section due to my lack of knowledge. So what is physiological interpretation of CTG? If this is what we are currently doing, what is the other side of the coin that we should be doing? Well, that's physiological interpretation of CTG. In a nutshell, is about treating each baby as a person, not as a part of a guideline, just like our general practitioners and other doctors would do. So the first thing is to exclude pre-existing or chronic hypoxia. The next is to determine fetal response to stress, asking the question, how is this baby doing at this given time? The third issue is to look at the features on the CTG and determining what is the type of intrapartum hypoxia the fetus is exposed to. And finally, considering the wider clinical picture, because if I'm infected, I cannot run the same distance. If mom has pyrexia, I cannot run the same distance. I can't dissipate my heat. If I'm covered with meconium, and if I'm exposed to hypoxic stress, I have an increased chance of meconium aspiration syndrome. So I cannot do the same things that other fetuses are doing. You need to treat me differently according to my situation. You might ask, come on, Edwin, really? Does it work? Well, I was for 2 years, last 2 years, I was working at the Mid and South Essex NHS Foundation Trust, which is one of the largest hospital trusts in the UK, with 12,500 births per year. And I was at this hospital until May 2022. And you can see when they were using NICE guidelines in all 3 hospitals, the red bars tell you the number of babies with severe brain damage, hypoxic ischemic encephalopathy, and brain damage in 1 year out of 12,500 births. The moment they train their staff to ask a question, how is this fetus, understand the type of hypoxia, and then introduced consensus guidelines, international consensus guidelines on physiological interpretation of CTG, produced by 34 CTG experts from 14 countries around the world who know and understand fetal physiology, then you can see the change. So the number of babies with brain damage dropped by over 60%, and that is the impact. And if you want to look at it slightly differently, this is naturally 1.5 to 2 points per thousand. And this is in the hospital, 3 hospitals together, they had a rate of 2.4 per thousand. The moment you stop that national normal suspicious pathological and start asking, how is this fetus? By understanding fetal physiology, this is 0.8 per thousand. Now, fetuses, just like us, they have some requirements. They want to have uninterrupted oxygenation from the placenta, so the myocardium is continuously oxygenated to be in the aerobic metabolism. And they want to have a normal metabolic demand. So you can imagine, if I'm a macrosomic fetus, because my mom is giving me too much of sugar in gestational diabetes, my metabolic demands are higher. And therefore, I cannot withstand the same contractions, the same oxytocin, for the same duration as another fetus in room 2 who has got normal growth. If I've got chorioamnionitis, my metabolic demand increases, and therefore I cannot be subjected to the same contractions which reduce oxygenation. As long as this balance is maintained, I'm going to have a good cardiac output. I'm not going to have hypoxic ischemic encephalopathy due to an intrapartum cause because I maintain this equation and my heart is in positive aerobic balance. And now if you imagine, continuous supply of oxygen is important, which happens in the antenatal period. And all my carbon dioxide and waste products also go back through the placenta, through the uterine vein to be excreted by the mom. So I'm in a very good state. But then labor started. Labor means interruption of oxygen. Put yourself as a fetus on this side and ask yourself, what's the problem? If my mom is contracting, that means my branches of the uterine arteries supplying the placenta are squeezed during a contraction. I'm not going to get oxygen. And this carbon dioxide cannot go out because the uterine vein is also squeezed. So I'm going to have accumulation of my metabolic byproducts on my side and lack of oxygen on my side during a contraction, which means the amount of oxygen that is going to my central organ is going to be reduced. So this fetal oxygen cylinder is so important. So each of these interruptions are going to reduce the oxygenation to my central organs. But I'm a clever fetus. I need to do something about it because I don't want to get damaged. I don't want to die over the next 8 hours because I'm here. And my mom is cutting off the oxygen by squeezing the placental blood supply and umbilical cord. And I don't want to have hypoxia and acidosis in my central organs. And I know that I can't breathe because the oxygen is outside my mom and I only have amniotic fluid. So about 2 million years ago, human fetuses thought, let us evolve intelligently because we can't use the heart-lung mechanism when you're in the inside the uterus only because you don't have oxygen in your atmospheric air to breathe. Your atmosphere is amniotic fluid. So we know as human fetuses, if contractions reduce the blood supply, the myocardium will be in a situation where the amount of oxygen delivered to the myocardium is less than its demand. Then what happens? We go into anaerobic metabolism, just like in the gym having pain in the calf muscles. And that is going to produce lactic acid within the central organ, the myocardium. And then we are going to have a step ladder pattern to death and terminal bradycardia. And we will not allow that to happen because we are intelligent human fetuses. So what do? Each time the mom squeezes the blood supply out of us, we couldn't increase the supply like a toddler, a child, or an adult playing football. Finished. We couldn't do that. And therefore, we invented something wonderful. And that's called a deceleration. Because when your supply is reduced, let's say this is your supply-demand equation, you are happy. Suddenly your supply is reduced because of uterine contraction. You're going to have anaerobic metabolism because your demand is higher than the supply. So what do? You reduce the demand, you hibernate. So you make your supply-demand equation same during a contraction. When you do that, there is no risk of anaerobic metabolism because you can only become anaerobically, go into anaerobic metabolism if you have the heart receiving less oxygen than its demand. Then you switch from aerobic to anaerobic metabolism to produce lactate. So when the supply falls, if you also manage to reduce the demand to maintain your equilibrium, you're fine, absolutely fine. So transient episodes are absolutely fine. And that is your compensating mechanism. So your decelerations are the fetal counterparts of adult respiration. In the FIGO guidelines and in the physiological guidelines, we have defined decelerations as reflex responses to reduce myocardial workload to maintain a positive energy balance. Life is about maintaining a positive energy balance. When you come out as a fetus, when you're a toddler, you will maintain the positive energy balance by breathing faster. When you're inside, when you cannot breathe faster to oxygenate your myocardium, you will maintain your positive energy balance by reducing your demand. The good example I can give you is that if you run in the gym today, you will have pain in your calf muscle because your calf muscle has gone from aerobic to anaerobic metabolism to produce lactate. What if you stay at home on the sofa, watch TV? You won't have pain in your calf due to lactic acid because you haven't worked your muscle. It's only when you work your muscle without oxygen, you get anaerobic metabolism. So if you're an adult, when the supply to your myocardium is reduced, you know that you need to maintain the myocardium in a positive energy balance all the time to prevent acidosis. So what do? You increase both the rate and depth of respiration. And the faster you run, faster you breathe. And that is to maintain positive energy balance in the myocardium. If you're a fetus, when contractions reduce the supply of oxygen to your myocardium, you know that you need to do the same thing. You need to maintain the positive energy balance within the myocardium, but you cannot breathe faster because you don't have oxygen inside the uterine cavity. So what do? You reduce the demand, you show a deceleration. And both of us, both fetuses and adults, we do exactly the same. Our aim is the same, to avoid anaerobic metabolism, to avoid lactic acidosis. So when we looked at physiological interpretation of CTG, we were able to show that the morphology of the deceleration, how ugly they look, whether they are late, they are variable, whatever name you want to call them, they have no correlation to the perinatal outcomes. Okay, so what is important is how the fetal organs are oxygenated based on what they show you on the CTG traits. And this is the reason why, if you have attended our physiological CTG master classes, we recommend that after we understand the mechanism of decelerations, so that we can correct the problem, We use a 50 pence coin in the UK or in the European countries, 2 euro coin, because that's the largest coin we have. That will cover the biggest, ugliest decelerations to reduce the anxiety among obstetricians and midwives. And then look in between the decelerations to assess the fetal response to stress by asking the question, how is this fetus? So in the beginning, we saw how an intelligent human fetus does FIRA, fetal intelligence responsive adaptation. But they have a problem during labor when the myometrium contracts and reduces oxygenation. They respond in a very intelligent way. If you're an adult, when the oxygen is less, you increase the rate and depth of respiration to maintain aerobic metabolism. If you're a fetus, you do reflex reduction in the myocardial workload, deceleration to protect your myocardium. So we need to learn a lot from our midwifery colleagues. Midwives are very intelligent. You know what they do? They know that during a contraction, the baby's head gets squeezed, umbilical cord gets squeezed, and the placental blood supply gets cut off, and there's pressure on the head. And therefore, it's crazy to listen during a contraction because you will expect a change in the heart rate during a contraction. And that's not pathological, that's physiological response. It's a normal physiological response. If I come and pinch you, your heart rate goes up. You're not going to die of sepsis. No, that's due to the mechanical stimulation. In the same way, during labor, when there are contractions, the fetus is going to get squeezed. The vagus, parasympathetic nervous system centers are going to get activated, and you're going to see a change in the heart rate during a contraction. That's why midwives are clever. Their guideline says, when you do intelligent auscultation, listen immediately after the contraction. Immediately after. Because what are they trying to do? They are looking for fetal response to stress. So if this fetus is stressed, but then is unable to deal with that stress, if it is too much, as the fetus recovers, when the fresh blood comes from the placenta, they would show a change in us, saying, please look after us, because we are not like the fetus in room 2. We are showing you a change in the baseline, and that is very important. So midwives listen immediately after the contraction. What did doctors do? Because we introduced CTG without any scientific evidence, without understanding human physiology, we tried formulating guidelines which treated physiological responses as pathological. We created crazy guidelines that made doctors and midwives to count these for 30 minutes, look how ugly they are looking, and then to do an intervention. And we are wondering why in the Western Hemisphere, in most countries where they introduced normal suspicious pathological guidelines, the cesarean section rates are going up, accreta, increta, procreta rates are going up, and the Cochrane systematic review is saying we haven't changed any outcomes. So the perinatal outcomes haven't changed. If women are having more cesarean sections and the cerebral palsy rates are coming down, you might say, well, that's a trade-off. Here, women's cesarean section rates are going up, accreta, increta, procreta rates are going up, but we haven't changed perinatal outcomes. And that's because we failed to learn from our midwifery colleagues who are doing the right thing. They are looking for fetal response to stress by listening immediately after the contraction when they are looking after a human fetus. We are looking for stress and panicking about stress, which is a natural human situation. When you are running in the gym, would you want a live gym trainer to drag you out of the treadmill because they don't like your respiratory rate and give you oxygen or ventilate you in the gym? No, that is your response. Yeah, you will look a bit ugly when you go faster, but you're not gasping to die. You're not having bronchial asthma. You're not having sepsis. That's your physiological response. You don't treat physiology in clinical medicine. Just imagine if they come and do a colostomy every time we defecate in the morning because they think that that is bad. No, physiology is good. That's what makes us humans. Decelerations are very good for a human fetus. If a fetus is unable to drop the heart rate to protect the myocardium, that fetus is in trouble. In the same way, if I have chronic pulmonary obstructive disease, and I cannot increase the rate and depth of respiration when I'm running or going to the gym, I'm going to die. The larger breaths I take, the deeper breaths I take, I might look ugly to you, but I'm okay. And that's only because I'm doing a physiological exercise. And this is my physiological response. So we were able to show that even if you have repetitive, variable, or late decelerations, and even if the baseline heart rate that hasn't gone up without any catecholamine response, as long as the baseline variability that tells you about the central organ system oxygenation is normal, all fetuses had normal Apgar scores and normal umbilical cord pH. So just take a step back. We were lucky in the UK because a couple of 100 years ago, Sir Isaac Newton, he asked one question: why is the apple falling down and it's not going? Because he asked the question, because before him, everyone ate the apple. They didn't think. He asked that question. Then the laws of gravity came and humans were able to conquer the moon. All because of that apple and the thinking that came from the apple. In the same way, in 1968, when CTG was introduced into clinical practice, if one of our professors who made these guidelines, normal, suspicious, pathological, asked one question like Sir Isaac Newton, why is the baby's heart rate going down and not up? They would have found, and that's because around the baby, there is amniotic fluid. And the only way you could maintain your cardiac equilibrium, aerobic balance in the myocardium, is to slow down the heart rate. If they had done that, lots of women would have avoided unnecessary cesarean section. Lots of babies would have been alive instead of dying because water or fluids are given to the wrong person for suspicious CTGs, misclassifying chronic hypoxia and chorioamnionitis as suspicious, because those babies are not going to show much changes. You will see in the next talk. And this crazy classification of grouping individual features into boxes and then calling it normal, suspicious, pathological would not have happened. And we would have asked the question 50 years ago by understanding fetal physiology, looking at the changes in between the deceleration, asking the question, how is this fetus? Same as midwives when they do intelligent auscultation. So please remember that physiological interpretation of CTG is about considering the fetal response. It is not about panicking about decelerations. It is not about counting them, determining how ugly they are. When you are in the gym, depending on the exercise you take, your respiratory rate will change. If you start oxytocin, these decelerations are going to become progressively uglier because the baby has to drop the heart rate to protect the myocardium for a long time. The question is, how are they responding to that stress? How are they ensuring central organ oxygenation? And that's what physiological interpretation of CTG is. And you can see here, this fetus is absolutely having a stable baseline. That means the myocardium is well oxygenated, it's not fluctuating. So when you see a stable baseline, which is appropriate for gestational age, then you say this myocardium is fine. But now they have started oxytocin. You see the contractions. Each contraction squeezes the umbilical cord, cuts off the placental blood supply. And some of those contractions are coupling contractions. So you don't get enough blood coming through. As a human fetus, an intelligent human fetus, what do you do when your oxygen is cut off to the myocardium? You cannot breathe faster to get more oxygen. So what do? You slow down. You slow down. You slow down to protect the myocardial workload. But in between the deceleration, you still have a stable baseline and reassuring variability. So you are showing a gradually evolving hypoxia, which is compensated. But if the stress continues, you need to perfuse faster to get more oxygen from the placenta and also to supply the vital organs at a faster rate. So you release catecholamines. when you get catecholamines in your system, your heart rate increases to perfuse faster. At the same time, after some time, you start redistributing from non-essential organs to essential organs. So as long as the baseline variability is stable, baseline is stable and the variability is normal, you are having a compensated stress, a gradually evolving hypoxia, which is compensated with catecholamine response. But this is the time when you and I have to go look at the labor. Is she a primigravida, multigravida? How far has she progressed? What else is happening? Meconium temperature. Make sure that we, unless the woman is about to deliver, reduce the stress so that we bring the baby back to its normal physiology to continue. So we were able to show that even there's catecholamine surge after repetitive variable or late decelerations, as long as the fetal heart variability remained normal, all the fetuses were born with normal ABGAS and cord pH. So it doesn't matter how many decelerations, how long they're going in for, they're all physiological responses. No one comes and counts your respiratory rate in the gym because it's useless, but they will count your respiratory rate in the hospital when you have sepsis, but not in the gym, because the faster you run, your respiratory rate is going to respond to that. That's your compensatory mechanisms. In the same way, decelerations are fetal compensatory responses, and therefore they will change according to the stress they are exposed to. And the duration depends on how long the stress is lasting. But look in between. If you have a stable baseline and reassuring variability, that fetus is not acidotic. Even if the fetus has increased the heart rate to get more blood, as long as the variability remains normal and the baseline is stable, there is no acidosis. Then the question comes in second stage of labor, or if you have given too much of oxytocin. As a fetus, I have now what is called a rapidly evolving hypoxia. It's coming a bit too fast. What do? I have less blood going through the carotid artery because I'm not getting enough. I'm trying to pump. And the sympathetic says, come on, guys, increase the heart rate. I need more to the brain. The parasympathetic says, no, in hypoxia, you need to protect your myocardium first. You need to slow down. Because if you develop acidosis in the myocardium by pumping faster when there's no oxygen, you're going to have lactate. So please slow down. And sympathetically say, no, I want more to the brain, go up. And this abrupt up and down movement across the baseline is what is called a ZigZag pattern. And this is very, very important. So you can see a ZigZag pattern. Sadly, some of the guidelines don't talk about it, and national guidelines in the UK, they even got it so wrong by putting one number. Imagine in the medical ward, instead of having 4,000 to 11,000 as the number, the normal range for leukocyte count, those professors say anything more than 4,000 is normal. If I go with sepsis, with the leukocyte count of 23,000, they will mark me as normal because they have only one number, more than 4,000. Imagine the cardiologist, instead of saying adult heart rate 60 to 90 is normal, that's a range. So more than 90 is tachycardia, below 60 is bradycardia. They only give one number, more than 60. So when I go with supraventricular tachycardia of 200, those nurses and doctors will say, Edwin, you're normal. You know why? My professor says, if the heart rate is over 60 is normal, and your heart rate is 200, is more than 60, is normal. And I die. And then they have an serious incident panel to find out why I died. And they blame the staffing, underfunding, poor culture, missing the point that the tool is the one that is wrong. You know, sadly, in my medical legal practice as an expert witness, I've seen so many babies getting damaged and dying because in the UK, until 2017, after many of us wrote, and there was an exceptional review in the guideline within 2 years of publishing that crazy guideline. Until then, babies were lost because we didn't get basics right. Humans cannot have one number. We are not robots. We have a range for everything. Our liver function is a range. Imagine if you say ALT more than 10 is normal. When there's hepatitis and we have an ALT of 100, we'll be normal because more than 10. So here, so many babies, sadly, we lost because if you don't understand physiology and if you call increased variability as normal, it is more than 5, you're going to have a myocardial failure and poor outcomes. So we looked at 500 cases when we published first on the ZigZag pattern, and we were able to show that if the ZigZag pattern lasts for more than 2 minutes, there was a significant increase in the admission to the neonatal unit. And subsequently, Mikko from Finland, he had looked at with his team 5,000 cases and he had the same conclusion. So remember, in a rapidly evolving hypoxia, don't expect the variability to get reduced because it's not acidosis. It's too rapid to develop acidosis. You would expect the variability to increase due to autonomic instability. So you and I have onset of stress, babies have an onset of stress, and they compensate for the stress. And some of them are unable to deal with it, and therefore they go from aerobic to anaerobic metabolism. They undergo decompensation. It's a decompensation that can cause neurological damage or death. So we need to be intervening here when there is the onset of decompensation to avoid that from happening by understanding compensatory responses and to have appropriate interventions so that compensation doesn't become decompensation. That's where we need to be at. If we try to panic about decelerations and run around classifying them as normal, suspicious, pathological, typical, atypical, we are missing the point. We are doing too many cesarean sections without any improvement in the outcomes. That's what Cochrane Systemic Review has told us. However, if you don't understand basic physiology and chronic hypoxias and chorioamnionitis are classified as suspicious, then we are missing the baby. And those are the babies who collapse due to decompensation. And if a fetus is coming with pre-existing problems like chronic hypoxia or chorioamnionitis, just like if I have a coronary artery disease, and then go to the gym, I can't undertake the same exercise. I can't show you the same responses because I have a problem, pre-existing problem. And therefore, those babies might go from the onset of stress. If you allow contractions to continue or start, they can rapidly undergo decompensation and get into neurological damage or death. So when we are trying to move from patterns to physiology, it's about asking certain key questions. First thing is, do we understand the mechanisms of intrauterine fetal stress? The second question is, do we know how to determine the response of the fetus to ongoing stress? What are the features on the CTG that tells us about compensatory responses? What are the features on the CTG that tells us about decompensation? But life is not about hypoxia alone for a human fetus. What about those features in the CTG that we should be looking for in chorioamnionitis, fetal-maternal hemorrhage, chronic fetal anemia, and acidosis? And what about the fetus who is coming to us at the beginning of labor with pre-existing damage? What are those features? So that we don't just call them suspicious because we don't have ugly decelerations. And then we ask the question, how is the fetus? So the International Consensus Guidelines on Physiological Interpretation of CTG was published in 2018 by 34 CTG experts from 14 countries. And it has, at the beginning, it recommends a checklist. And the checklist to make sure that the brain, heart, and the placenta are functioning well at the beginning of labor. So that we can ask the question, is this fetus in room 2 fit to undertake a progressively hypoxic journey of labor? Remember, the journey of labor is quite different to running a marathon. Marathon, you and I can control the speed, but labor babies have no control of the speed. And the contractions are going to get progressively stronger, longer, and has more strength as labor progresses. So if you are having a fetus at 2 centimeters showing evidence of chronic hypoxia, At 8 centimeters, the hypoxic stress is not going to be the same for that fetus. So all the hospitals which use physiological interpretation of CTG, we use a checklist at the beginning to exclude pre-existing hypoxia. And then during labor, we use a tool each time when we look at a CTG to ask the question, how is the fetus? And you can see there are no numbers here because we cannot use population data to manage individual patients. Our doctors don't do it, our pediatricians don't do it, and our general practitioners don't do it, and we should be doing it. We compare each baby with the same baby from the beginning. Has there been a 10% rise in the baseline due to catecholamine surge or chorioamnionitis? We don't just count the contractions to work out hyperstimulation. Do we have intercontraction interval of more than 90 seconds? That's based on scientific evidence. So if you have increased duration instead of frequency, the intercontraction interval, the interval between the two contractions will get smaller. And that's what affects the baby's oxygenation. We have to look for the phenomenon of cycling. Is the variability less than 25 or more than 25 zigzag patterns? We have to look at the features on the CTG to see, are the central organs well oxygenated? And then any signs of chorioamnionitis or infection and other abnormal patterns which happen in non-hypoxic causes like the zigzag pattern, sinusoidal patterns. And this study from Spain, which compared the FIGO guidelines, ACOG guidelines, NICE guidelines, and the physiological guidelines to look for as prediction of neonatal acidemia, they found that the physiological guideline has the highest capacity to predict acidosis. So to conclude, the concepts of physiological interpretation are, the main concept is treating each fetus as a person, not to compare a fetus based on a guideline of population, but as a person. First, excluding pre-existing hypoxia, then determining how is this baby responding to stress by looking in between the decelerations to find out how is this fetus. Then by looking at the CTG, looking at and determining the type of intrapartum hypoxia, and finally making a decision as to how best to manage these babies by putting the other factors that might independently affect the outcome, especially chorioamnionitis, presence of meconium, etc., so that we can help these babies. So why today is the right day for an urgent paradigm shift? And the part two is to ask the question, why? Why should we change? Thank you very much.